Welcome back to the Deep Dive. Our mission here is to take complex source material and, well, distill it into actionable, memorable knowledge, giving you that critical shortcut to being truly well-informed. Today, we're diving deep into a topic that is absolutely foundational for public health nursing and, for successful community practice.
Yeah, we're talking about health education in the community.
Exactly.
And this is a deep dive tailored specifically for you, the learner. We're really focusing on the essential role nurses play in shifting the health conversation.
Shifting it from what? The sick individual to the whole population.
Precisely. From the individual to the well-being of entire populations. Our source material isn't just about what to teach. I mean, it's a detailed guide on how to design, implement, and rigorously evaluate these large-scale educational programs.
So the goal is making sure the knowledge actually sticks.
It has to stick, and it has to translate into lasting behavioral change, across whole groups and communities.
Okay, let's unpack that core concept a bit. The sources seem to really emphasize that the ultimate goal of community health education isn't to just lecture people.
No, not at all. It's not about dictating behavior.
Right.
The goal is to teach people what they want to learn, and to do so using strategies that, genuinely facilitate that deep learning. It's all about empowering the learner, and that starts with their active participation in identifying their own needs.
And that's why the nurse is so perfectly positioned for this role.
That's precisely why. The nurse is the ideal leader in this space. I mean, think about it. Nurses are these trusted professionals who operate across the entire spectrum of care.
They're everywhere.
They're everywhere. They educate clients at all three levels of prevention: primary, which is, preventing problems before they even start.
Right.
Secondary, which is early detection and treatment. And then tertiary, which is all about minimizing disability and maximizing function after something has already happened.
And they work with everyone: individuals, families,
small groups, and even enormous community systems. So this comprehensive reach makes them the perfect conduit for population health knowledge, really helping clients attain optimal health and take responsibility for their own informed decisions.
So if the nurse is the ideal guide for this, what's the blueprint they're supposed to follow? I see the source material lays out a pretty clear, systematic 6-step process for developing these programs.
It does.
It feels a lot like the standard nursing process: assessment, planning, implementation, evaluation, but just scaled up.
It absolutely mirrors that structure. It provides a really rigorous framework. So the first step, just like assessment, is identifying a population-specific learning need.
Okay.
And you need data for this. You can't just guess. Is it asthma management for high school athletes? Or is it addressing the alarmingly high rates of childhood obesity in one specific district? The need has to be concrete and measurable.
So once the problem is defined, we move into the planning phase.
Right, the theoretical space of planning. So step 2 requires selecting one or more appropriate learning theories to guide the design of the program.
And this isn't just for show, right? These theories matter.
Oh, they matter a lot. This isn't theoretical window dressing. These models actually determine how we approach motivation and how we stage change, which we'll get into in a lot more detail later.
Okay.
Then step 3 is about selecting and applying educational principles, making sure that the chosen methods are feasible, ethical, and really tailored to maximize the chances of that learning being accepted within that specific population.
And before you actually implement anything, the planning has to account for, I guess, real-world friction.
That's a great way to put it. That's step 4, examining crucial educational issues and barriers. This is where the nurse has to get granular.
Looking at things like culture or age-specific needs.
Exactly. Culture, age, and maybe most critically, identifying any literacy hurdles. This examination guides the nurse in selecting the absolute best teaching and learning strategies based on that group's demographics and their expressed needs.
And then comes the action phase.
Step 5 is the execution. You design and implement the actual educational program using those carefully vetted strategies. And then step 6, which closes the loop, is the rigorous evaluation of the program's effects.
Did it work?
Yeah. Did the knowledge transfer? Did the community's behavior actually change in the way you wanted? This final step is what dictates all your future modifications.
So this systematic approach, it operates within a much larger national context.
Yeah.
And that brings us to Healthy People 2030.
Right.
This national agenda seems to fundamentally rely on the success of the nurse's educational role, especially in health communication.
It really does. I mean, the success of almost every single objective in Healthy People 2030 hinges on whether health communication is clear, accessible, and leads to shared decision-making. The document explicitly points out that healthcare information is complex, and providers have to proactively use tools like the teach-back method to confirm understanding. And this extends to the digital realm, too, ensuring electronic health information is accurate and easy to use.
Our sources pull out 3 specific healthy people 2030 objectives that really mandate the need for this kind of deep dive.
They do. The first is HCHITR01, which is all about increasing the overall health literacy of the population.
Which makes sense. If people don't understand, nothing else works.
Exactly. Without basic comprehension, all other interventions they fail. Second is HCHITR6, and that focuses on increasing the proportion of adults who are offered online access to their medical records.
So embracing the digital shift.
It acknowledges that irreversible shift toward digital patient engagement and, the need for digital literacy. And finally, ECBP-D03, which aims to increase the proportion of work sites offering employee health promotion programs.
Using the workplace as a setting for health education.
Yeah, establishing the workplace as a vital and, frankly, a captive setting for community health intervention and education.
I find it incredibly compelling that the source material ties all of this need for behavioral education to the emerging field of genomics. We've spent so many decades thinking of certain health risks as just locked into our DNA.
Right.
But the research here offers a really empowering counterpoint.
This is where you see that fusion of science and health promotion. The research cited, particularly about the FTO gene variant, it's groundbreaking. FTO is often called the fat mass and obesity associated gene.
Okay.
And people who carry this variant have a significantly increased genetic risk for obesity.
So a nurse might run into a client who just thinks their weight struggle is, an inevitable genetic destiny. There's nothing they can do.
Precisely. But the research, this was from the University of North Carolina, found that it's not destiny, it's predisposition. They show that individuals carrying that high-risk FTO gene variant can actually reduce the effect of their DNA and their risk by about 30%.
Just by exercising.
Just by engaging in regular, sustained physical exercise.
Wait, so the source is telling us that a high-risk genetic marker isn't a final sentence. I mean, that's a fundamentally empowering message for public health.
It's huge.
So how do nurses make sure that specific message, that your behavior can interrupt your genetics, is part of their toolkit?
Well, that knowledge provides a powerful internal motivator. It shifts the whole narrative from I am doomed to I have a choice and I have control. So the nurse's educational role here is twofold.
Okay.
1, to transmit the cognitive knowledge about their gene risk, and 2, to address the affective domain, to build that self-efficacy and belief that their behavior matters, even against a genetic predisposition.
So education in this case moves from just generalized wellness advice.
Exactly. It moves to highly personalized, evidence-based empowerment.
Let's transition now from that big systemic framework to the fundamental mechanics of what we're trying to achieve here. We really need to define the difference between education and learning. They might seem like the same thing in a normal conversation, but in this context, they represent really distinct clinical processes.
That distinction is paramount when you're designing interventions. Education is the activity itself. It's the planned curriculum, the materials, the lecture, the demonstration. It's all designed to help people change their knowledge, attitudes, and skills.
Okay, so education is what the nurse does.
Right. And learning, on the other hand, is the process that occurs when the recipient actually absorbs and processes that information, and it results in a demonstrable change. Education is what the nurse does. Learning is what the client achieves.
And the source material gives us a roadmap for that, right? It basically says, hey, giving someone a new fact is easy, but getting them to actually live that fact, that's the real challenge.
Yeah, the Everest of behavior change.
It lays out a clear difficulty hierarchy.
The difficulty of achieving change, it increases exponentially. So knowledge is the least difficult area to impact. Facts are relatively easy to transmit. Attitudes are next. That requires challenging existing beliefs and values, which is much, much harder. And then the most difficult area, which is the ultimate goal of public health, is changing behavior.
So nurses provide the knowledge and support, but they have to recognize that the behavior change itself is the biggest hurdle.
It's the biggest hurdle. And the acceptance of any new information is never a blank slate. Everything is filtered through the learner's existing framework, their prior knowledge, their deep-seated cultural values, generational experiences.
Right. A person isn't a vacuum.
Exactly. Well, an effective health educator knows that. They need to understand those filters. And to organize instruction, the sources rely heavily on the three learning domains that were developed by Bloom and his colleagues back in 1956.
Okay.
And understanding these domains is essential for structuring any effective learning session.
Let's dive into those. The first one is the cognitive domain. This is the realm of thinking.
Right.
So this covers everything from just simple recall to, complex problem solving.
Everything. And the cognitive domain is critically important because it's hierarchical. You have to master the foundational levels before you can really engage the higher order thinking skills.
So there are steps.
There are 6 components, and they move from simple to complex. It starts with knowledge, which is just the recall of information, defining terms or listing facts. Next up is comprehension, where the learner goes beyond just recall to explain or summarize the facts in their own words. It shows a basic understanding.
Okay, and then we move from just understanding a fact to actually applying it.
That's application. The learner takes the new information and uses it in a different, concrete way. For instance, knowing the principles of a low-sodium diet and then using those principles to read a new food label and make a choice.
I see.
Step 4 is analysis, and this is a pretty big jump. The learner breaks down the communication into its component parts to understand the underlying structure, the relationships between those parts. They're analyzing why a diet works, not just what it is.
And the final, most complex stages. This is where that real critical thinking comes in.
It is. Step 5 is synthesis. Here, the learner combines the parts they just analyzed into a completely new whole or a new structure. In an educational setting, this could mean designing a week-long personalized meal plan based on all the factors they've learned about. It requires creative construction.
And the top of the pyramid.
The apex is evaluation. This is the highest level of cognitive processing. It's where learners judge the value of what has been learned against some kind of predetermined standard. They decide, is this information reliable? Is this intervention effective for me?
I can see why assessing cognitive abilities first is so important. I mean, if you try to teach analysis or synthesis to someone who's struggling with basic comprehension, you're just guaranteeing failure.
And immense frustration for everyone. Nurses need to use simple tools to assess literacy, and we'll talk more about those later. But the point is, your teaching has to match the cognitive readiness of your learner.
Okay, so next is the affective domain. This is focused on feeling attitudes, values, beliefs. This seems so much harder because it deals with the emotional investment in change.
It is the hardest domain to influence. It involves changing really deeply rooted beliefs, interests, and values. The nurse has to be a really astute listener, picking up on clues about feelings that might impede or influence learning. Changing attitudes, it takes time, repetition, and tremendous support from the client's environment and social network.
Does the affective domain also have a structured set of steps, like the cognitive one?
It does. It's also a 6-step hierarchy, and it details the journey from simple awareness all the way to full internalization of a value. It starts with receiving, where the learner simply becomes aware of and attends to the information. Then they respond, which shows interest or, at least minimal compliance.
So they're moving from just being passive to being a little more engaged.
A little more. And then step 3 is valuing attaching worth to a phenomenon or a behavior. For a smoker, this might be valuing breathing health more than the pleasure of smoking. Step 4 is making sense, where they organize those values internally. Step 5 is organizing, which is integrating a new value into their broader value system, weighing it against other priorities. And then finally, the ultimate goal, adopting behaviors that are consistent with that new value system. And that's often the true measure of success in effective change.
That journey from just hearing a fact to organizing your life around a new value seems extensive. So finally, we have the psychomotor domain. This is the domain of acting or skills.
Right. This is all about physical dexterity and neuromuscular coordination.
So things you do with your hands.
Exactly. This domain is focused on teaching motor skills. Think about wound care, measuring blood glucose, self-administering an injection, or even just using crutches. The learning here is highly observable, which makes evaluation immediate. The nurse first provides a clear sensory image pictures, models, videos, or a live demonstration. Then the client has to engage in repeat demonstration.
And what are the 3 non-negotiable conditions for a learner to actually master a psychomotor skill?
So first, the learner has to have the necessary ability. And this includes both the cognitive understanding of the steps and the physical capacity. For example, a nurse needs to know that an older adult with severe arthritis might physically struggle to open a child-proof medicine container, that requires a different solution.
They also have to be able to visualize success, right?
Exactly. Second, they need a clear sensory image of the skill, meaning they can mentally walk through the steps. If you're teaching heart-healthy cooking techniques, ask them to visualize their own kitchen layout, where they store ingredients. This connects the abstract skill to their reality.
Okay.
And third, they need opportunities to practice the new skills in an environment that's relevant to them, adapting the skill until it's just integrated into their routine.
Let's use the case study from the text to really show how all three of these domains apply at the same time. The example is a nurse teaching a group of women newly diagnosed with diabetes.
Right, so the intervention has to hit all three targets. The cognitive domain addresses their immediate need for information. What is diabetes? What are the basic dietary rules? What are the symptoms of, hypo and hyperglycemia?
The facts.
The facts. Then the psychomotor domain is all about technical mastery. How do they use the glucometer? How do they draw up and perform an insulin injection? The nurse has to ensure they have the dexterity, and that's through demonstration and immediate return demonstration.
And the affective domain has to address that emotional resistance that comes with a chronic, life-altering diagnosis.
And that's often the hardest part. The women might be in denial because they feel pretty okay early on, which makes them resistant to long-term changes. So the nurse needs to address that denial, help them acknowledge the perceived severity of future complications, and ultimately help them value long-term health and the control they get from self-management. The educational plan has to be holistic. It has to address the head, the hand, and the heart.
That brings up a critical point about communication, which ties directly to the QSEN competencies, the quality and safety education for nurses. So if a nurse is teaching, say, 4 women about wound care after surgery, how do you make sure the message sent is actually the message received, really emphasizing that client-centered care?
Right, because poor client-centered care happens when we just assume understanding. To truly embody those QSEN competencies, knowledge, communication skills, and attitudes, the nurse should follow a really detailed sequence.
Okay.
First, provide clear, simple information describing the steps. Maybe use a culturally appropriate handout or a video, ideally in their native language. Second, the nurse performs a complete demonstration of the cleaning and dressing change.
And third,
And this is the most crucial part, the nurse asks each woman one by one to repeat the cleaning and dressing process right then and there.
that's the formal assessment of the psychomotor domain and an immediate check for clarity.
Yes. And finally, the nurse makes sure the plan aligns with their values and resources, asking about what supplies they have at home, the cleanliness of their living situation, any lingering concerns. This respects their values and preferences, and it ensures the instruction is not only understood, but also feasible within their reality.
Let's move now into section 2, where we get into the nuts and bolts of program design, starting with step 1, the needs assessment. This is where the nurse goes from a general awareness of a problem to specific, targeted learning objectives.
The needs assessment is the cornerstone. Without it, you're just guessing at what to teach. Our sources detail 5 systematic steps to get this right. First, the nurse has to identify what the client, whether that's an individual or a whole population, wants to know.
So you start with their interest, not just what you think they need.
You have to, that's the hook. Step 2 is rigorous, collecting data systematically. This means gathering comprehensive information on their existing learning needs, their readiness to absorb new information, and any potential barriers that might interfere. This could be surveys, interviews, community data.
Okay.
Step 3 is analyzing that data to identify those specific cognitive, affective, and psychomotor learning needs. For example, does the community lack knowledge about healthy eating, or do they lack the skill to prepare healthy food? Those are 2 very different problems.
And once we know the need, we have to address the motivation, which is so often the missing piece.
That's step 4, assessing what factors will increase the client's ability and motivation to learn. Is it a fear of consequences? Is it a desire for a better quality of life? The nurse identifies these drivers. And then step 5, working collaboratively, is assisting the client or the community to prioritize those learning needs, so you can focus your effort and resources on the most critical needs first.
Once the needs are assessed and prioritized, we define the scope using goals and objectives. This is a common point of confusion. How do you clearly distinguish between the two?
Right. Goals are the broad, long-term expected outcomes. They're like the overall mission statement. They're often aspirational and might take months or even years to achieve.
Can you give an example?
Sure. A goal might be To increase physical activity levels across the third grade population by promoting 30 minutes of daily physical exercise 4 days per week for 2 months. That's the desired behavioral state.
And objectives are the marching orders to get there, the specific, measurable steps.
Precisely. Objectives are specific, short-term criteria. They're written as measurable statements of intended outcome, and they always imply an action. So for that same third grade class, a highly focused objective might be, within 2 weeks, 80% of children will be able to successfully demonstrate at least 2 structured physical exercises they have learned. If you can't measure it, it's not an objective.
Now I move to step 2, selecting appropriate educational methods. This is where the nurse decides how to actually deliver the plan.
The golden rule here is to match the method to the client's needs and the presenter's strengths. Simplicity, clarity, succinctness, those are always prioritized. But most importantly, you have to vary your methods to meet the diverse needs of the learners and to keep their attention over the course of the program.
What does that variation look like? I see 2 main categories here.
Yeah, we have the active involvement approach, which is often highly effective for behavioral change and retention. This includes things like brainstorming sessions, role-playing, high-fidelity simulations, interactive games, or structured group participation. The learner is doing, not just receiving.
Okay.
Then there is the more solitary approach, which is better for foundational knowledge transfer, things like watching a professional video, listening to a guest speaker, or reading printed materials. A successful program will blend both.
And what about adjusting these methods for specific populations that have physical or cognitive limitations?
Those adjustments are non-negotiable for equity and effectiveness. For a visually impaired client, printed handouts are useless. The nurse has to rely on detailed verbal descriptions and maybe tactile models. For those with hearing or language limitations, visual materials, professional translators, or native language materials are essential. And if a learner has attention limitations, which is common in the elderly or small children, the educator has to use creative methods. Frequent breaks, simple, distraction-free surroundings, and highly hands-on equipment or interactive tasks that demand focus. Interactive programs consistently outperform non-interactive lectures in almost every metric.
Let's discuss the human element here, the skills of the effective educator. We have this powerful teach mnemonic that guides the nurse's conversational approach.
The mnemonic forces the nurse to focus on the client before the content. So T stands for tune in, listen before you teach. Let the client's needs and concerns direct the content you prioritize. E is for edit information. We can't teach everything, so we have to teach the necessary, most specific information first. A is for act on each teaching moment. Recognize those spontaneous opportunities for education and always work to develop a trusting relationship.
And the final 2, C and H.
C is for clarify often. Seek frequent feedback to make sure your assumptions about their understanding are correct. This is where teachback fits perfectly. And H is for honor the client as a partner. Build on their previous experience, share the responsibility for learning, and respect their autonomy.
Beyond that mnemonic, the course has also detailed this crucial 7-step sequence of instruction. It defines the flow of a perfectly planned lesson. I understand that if you omit any of these steps, you often end up with just superficial learning.
That's the critical takeaway. It's a sequence for success. It starts by gaining the attention of the learners, that's the hook, and clearly explaining that the information is important and beneficial to them. Second, the instructor needs to state the objectives of the instruction right up front, setting clear expectations.
The learner knows what success looks like from the start.
Exactly. Step 3 is a key connector. Ask learners to recall previous knowledge related to the topic. This lets them build a scaffold, linking the new knowledge to what they already know, which really helps with memory retention. Then step 4 is the core delivery. Present the essential material clearly, organized logically, and simply, consistent with the learner's identified strengths and limitations.
Okay, so once the materials is presented, you have to make sure they can actually use it.
That's step 5, and it's crucial. Help learners apply the information to their specific lives and situations. This moves information from abstract theory to concrete utility. Step 6 is the dynamic feedback loop. Encourage learners to demonstrate what they have learned. This lets the educator correct errors and immediately refine skills while the information is still fresh.
And
Finally, step 7 is to provide constructive feedback to reinforce correct knowledge and skills and encourage further improvement.
this systematic instructional design, it leads us directly into a major public health framework. Health communication and marketing, specifically the CDC model. Why does a public health nurse need to understand market theory?
Well, we use market theory because we are effectively selling health behaviors. Health communication is the strategic use of communication to influence decisions that improve health.
I see.
The problem is that healthy choices, like reducing sugar intake, often compete with readily available, highly marketed, unhealthy alternatives. We need a systematic approach to promote the product of health.
And the CDC uses a six-step process that blends traditional health communication with the social marketing.
It aligns beautifully with the nursing process. You start by describing the problem based on community data. Then you perform market research to understand the target audience's needs and barriers. Step 3 is defining the market strategy, which employs the famous 4Ps. Step 4 is developing the interventions, the educational programs or materials. Step 5 is to evaluate the plan, often testing materials with a small group before you deploy it fully. And step 6 is the comprehensive implementation.
Let's break down that marketing mix, the 4Ps, and apply this framework directly to public health action.
The 4Ps make interventions really concrete. The first is product. In public health, the product isn't always a pill or a syringe. It's the behavioral or health outcome itself, the adoption of daily exercise, the choice to get vaccinated, or smoking cessation.
The second P, price, is often misunderstood because it involves so much more than money.
That's right. Price includes both monetary costs, like bus fare to the clinic or the cost of healthy food, and non-monetary costs. And the non-monetary costs are often the greatest barrier.
Like what?
The time investment, the psychological effort needed for change, the discomfort of an injection, or even the loss of social standing when changing a behavior within a peer group. The nurse has to address these non-monetary costs.
And then, the logistics of access.
That's place the channels and locations where the product or service can be obtained. Is the clinic accessible? Is the educational material available online, in the library, or at the local community center? And finally, promotion, which is the communication strategy used to spread the message, direct outreach, publicity, PSAs, and advertising campaigns.
The source material gives a really clear recent example of applying the 4Ps to the COVID-19 drive-through testing stations in 2020. What was the critical public health analysis there?
The goal was mass, rapid uptake. The product being sold was the test-like service, the knowledge of your infection status. The price was strategically low on the monetary side, often free, but the nurse understood the high non-monetary price. The fear of diagnosis, the stigma of being positive, and the long wait times in line. By reducing the monetary costs and increasing the perceived benefit, they overcame that price barrier.
And place was the key differentiator for accessibility, it seems.
Absolutely. The place wasn't some remote clinic. It was a highly accessible drive-through station in a centrally located parking lot, which minimized contact risk and maximized convenience. And the promotion was massive, using public service announcements, government warnings, and high-visibility media campaigns to spread the message of availability, importance, and safety. This integrated approach, using the 4Ps, ensured that rapid, large-scale behavior uptake.
Moving on to specific delivery formats, Box 14.3 gives us examples ranging from large groups to highly focused skills training.
Right. The presentation format is used for large audiences, delivering consistent information. But because attention spans drop so quickly in large groups, the nurse needs engagement strategies. Structured discussion in breakout groups, immediate polling, or written reflection.
And for skills?
For skill transfer, demonstration is essential, like teaching the proper technique for an insulin injection or healthy food prep.
You also mentioned the power of small, informal groups.
Small informal groups are often the most powerful vehicle for effective change. Learners often gain as much, if not more, from sharing experiences with their peers than they do from the instructor. Imagine a support group in a domestic abuse shelter. The women jointly planning steps toward independent living. That shared vulnerability enhances trust and facilitates complex, effective change.
And then there's the community staple, the health fair.
Health fairs are really popular for primary, so prevention and secondary screening and early detection efforts. They are an interactive forum for screening, education, and live demonstrations like blood pressure checks or cooking demonstrations.
And the planning is a huge undertaking.
It's immense. The how-to box detailing the planning of a health fair shows just how complex it is. It stresses that forming the planning committee and developing the budget has to start up to a year in advance.
A year. That seems excessive for a single-day event.
Because you have 12 steps that require coordination and budgeting, identifying the target group, securing the venue, recruiting exhibitors who need their own lead time, arranging publicity, and ensuring adequate resources for screenings and follow-up. Skipping that early planning, like the post-event analysis and sending thank you notes, it just undermines the entire professional effort.
And the importance of cultural adaptation is clear, like holding an event entirely in a non-native language.
That's essential cultural competence. If a nurse is running a session for a new immigrant community, providing all materials and instruction in their native language, maybe Spanish, and staffing it with Spanish-speaking nurses, that signals respect and dramatically lowers the barrier to entry.
Before leaving methods, let's just revisit the critical need for ethical sourcing of information, especially with how prevalent technology is.
The nurse has an ethical and professional duty to vet all material. We live in a world saturated with health information posted by non-professionals, so nurses must always use trustworthy, peer-reviewed sources. They also have to be mindful of standards like HIPAA and institutional policies on social media use, like the ANA's principles, to maintain client privacy and professional boundaries.
We've talked a lot about complex instruction, but often the most effective tool is just using plain language. The Plain Writing Act of 2010 mandates this for federal documents.
Plain language is the foundation of health literacy. To design clear programs, Box 14.4 outlines four main planning points. First, content development must use trustworthy sources. Second, identifying the appropriate format and location. Third, organizing the learning experience for engagement. And fourth, the delivery plan itself.
Which means
Limiting the number of key points to 3 or 4, using a strong opening and closing, using an active voice, focusing on positive actions, and using vivid, concrete examples while strictly limiting complex statistics or jargon.
and what are the tools you use to immediately assess if that plain language was truly effective?
We use 2 really powerful tools. Teachback is the gold standard. It's the show me approach. The patient or the group immediately demonstrates or articulates what they learned back to the nurse. This isn't a test of the client, it's an assessment of the nurse's clarity, and it allows for immediate correction of misunderstandings.
And the other one?
A related strategy is Teach 3, which limits instruction to 3 or fewer critical actions, skills, or pieces of information at a time. This prevents cognitive overload and really maximizes immediate retention.
Let's apply all of this depth to the case study of Anna. She's a single mother who struggles with healthy eating because of her family's preference for fried foods and her lack of time, even though she genuinely wants to eat better.
Anna's situation is so common, and it highlights the failure of just simple pamphlet-based education. Her barriers, economic stress, lack of time, and family cultural norms around food are enormous. The nurse needs to deploy motivational interviewing MI techniques into the care plan.
So what does that look like?
First, the nurse has to express empathy, genuinely try to understand the world through Anna's eyes without judgment.
Recognizing that her struggle is legitimate, not just a lack of willpower.
Exactly. Second, the nurse must build self-efficacy by focusing on Anna's strengths, maybe she's highly organized at work, and helping her believe she has the internal ability to make small, feasible changes at home. Third, the nurse must roll with resistance when Anna expresses ambivalence or doubt. You don't argue, you explore the resistance.
And fourth,
The nurse uses techniques to help Anna recognize the dissonance, that her current action of frying food conflicts with her stated goal of healthy eating. The conversation would rely heavily on open-ended questions, affirmations to recognize her effort, reflections to show deep, non-judgmental listening, and summaries to ensure they're on the same page for the next small step.
moving to Section 3, let's explore the massive population considerations, issues, and barriers that a nurse has to navigate, starting with the fact that nurses begin with a huge asset: public trust.
That trust is indispensable. The Gallup poll consistently rates nurses as the highest professional group in terms of honesty and ethics, and this high level of public confidence places the community health nurse in an ideal position to introduce complex and sensitive educational topics across age and cultural boundaries.
In terms of age, the sources highlight 2 distinct educational models: pedagogy and rehabilitation. These define how the nurse has to interact with the learner based on their maturity and their prior knowledge.
Right. Pedagogy is the teacher-directed model. The instructor makes all the decisions about what, how, and when content is learned. This works really well for children who are generally dependent learners, or for adults who are entering a totally new field, say, learning about a complex new medical procedure, where they have no prior foundational knowledge.
And when you're dealing with adults or older adults who bring a lifetime of experience and knowledge to the table.
That requires andragogy. This model is highly learner-influenced and transactional. Adults are self-directed and problem-centered. They need to know why they're learning something and how it immediately applies to their lives. The nurse collaborates with the adult learner, and the learner influences the content and the pace. You have to choose the appropriate principles based on the population's age and existing knowledge base.
What are some of the specific practical strategies recommended for tailoring educational programs for younger children? They require a very different approach than the self-directed adult.
Children require highly concrete methods. First, use tangible examples and age-appropriate word choices. You tell a young child, brush twice a day. You explain to a preteen the benefits of plaque removal and the risks of gingivitis.
So it'd have to be concrete.
Very. Second, you have to use objects and devices, not just abstract ideas, to increase engagement. For example, letting children with asthma practice the proper technique using an empty inhaler device.
That hands-on experience really taps into the psychomotor domain in a way that abstract concepts just can't.
And third, you incorporate repetitive health behaviors into games or songs to aid retention and skill acquisition. A classic example is teaching children to sing Twinkle, Twinkle, Little Star while hand washing, because the song takes the exact recommended duration for effective germ removal. This turns an essential habit into an easily retained, automatic behavior.
Beyond age, we have to address cultural competence. The U.S. population is projected to be 50% ethnic minorities by 2050, which means culturally tailoring education is a professional mandate.
It is. Culture profoundly influences family structure, health belief systems, and interpretations of illness. The nurse has to achieve cultural competence, understanding the health belief systems of the specific ethnic populations they serve and tailoring the education to match that reality. This is enshrined in professional standards, like the Quad Council competencies, which stress using the social and ecological determinants of health to develop culturally responsive interventions.
Let's explore the example of providing tuberculosis education to Mexican migrant crop workers. What are the layers of cultural competence required there?
Well, the nurse first identifies that this specific group, often Spanish-speaking, with potential language barriers, lower socioeconomic status, and close working and living conditions, is at higher risk for tuberculosis.
So the intervention has to meet them where they are.
Exactly. That means going to their camp, using a professional interpreter for all oral content to ensure accuracy, and providing written handouts that are not only in Spanish, but are designed to be understood at a lower grade reading level. This holistic approach respects their language, culture, and literacy.
Now let's turn to the hurdles. Barriers to learning, starting with educator-related issues. These are common pitfalls for anyone leading instruction.
They're challenges every nurse faces. For instance, fear of public speaking. The strategy isn't to ignore it, but to conquer it through preparation, practice, and maybe even recording yourself beforehand. For a perceived lack of credibility on a complex topic, the nurse has to prepare meticulously and use data or stories that convey expertise, rather than apologizing for limited experience.
And dealing with difficult learners.
If you're dealing with difficult learners who disrupt the group, the nurse can use direct confrontation, humor, or, often more effectively, strategically dividing the group into smaller units to force participation from quieter individuals.
And what about just the practical issues, like equipment failure?
Always test your media and materials beforehand and have robust backup plans. If you are using a PowerPoint or video, have hard copies of key handouts. For timing, practice the presentation at pace. And when you're facing questions, remember two things. Concisely paraphrase the question to make sure you understood it, and recognize that it is always professional and appropriate to admit that you don't know the answer, and then commit to finding the resource later.
Let's pivot to what might be the most devastating barrier to learning. Learner-related barriers, specifically low literacy and low health literacy.
This is a massive public health crisis. Individuals with low literacy often go to great lengths to conceal this out of shame or embarrassment. They might nod along but fail to ask clarifying questions, which leads to severe consequences.
Like
Misinterpreting prescription labels, failing to follow up on discharge instructions, or misunderstanding critical health statistics.
the scale of this problem was rigorously measured by the National Assessment of Adult Literacy, or NAAL.
The 2003 NAAL measured literacy across 4 levels: below basic, intermediate, and proficient. It used 3 specific scales. Prose literacy is the ability to read and understand continuous text, like a newspaper article. Document literacy is the ability to read and interpret non-continuous documents, like a job application, a drug label, or a map. And quantitative literacy is the ability to perform computations, such as balancing a checkbook or calculating a dosage.
And the findings clearly illustrate the scope of the challenge for community nurses.
The results were stark. While the majority, 53%, were at the intermediate level, 14%, tens of millions of people, had below basic literacy. Scores were significantly lower for men, African American, Hispanic, and Native American adults, those over 65, and those living below the poverty line. For a nurse, below basic means a client often cannot even locate information in a short, simple text.
This feeds directly into the Institute of Medicine's definition of health literacy.
Right. Health literacy is defined as the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. Without this capacity, people struggle to understand the link between risky behavior and health. They fail to seek preventive care, they struggle to fill out complex insurance forms, and they cannot effectively manage chronic conditions.
The consequences of low health literacy are not just theoretical. They translate into massive costs and poorer outcomes.
They are severe and they burden the entire healthcare system. The inability to understand complex treatment plans or follow directions correctly leads to increased emergency room visits, higher hospitalization rates, more complications, and ultimately decreased life expectancy.
Why is it so prevalent?
Well, reasons include lack of educational opportunity, unrecognized learning disabilities, or what is called the use it or lose it phenomenon, where an adult's current functional reading level is typically 3 to 5 grades below the last year of school they completed.
So even if literacy isn't the issue, lack of motivation is another powerful barrier.
While external motivators like rewards or fear can initiate change, the sources stress that the most powerful drivers are internal. A person is motivated to learn and change if they truly value the outcome. They see a tangible benefit in a better life or improved self-esteem. They also must have a strong sense of self-efficacy, believing they can successfully follow through on the required action despite the difficulty.
We see the full convergence of low literacy, motivation barriers, and the overwhelming weight of social determinants of health in the food literacy case study of Alice Dobak.
Alice's case is a masterclass in complexity. She's a single mother, working 2 jobs, dealing with economic stress, and newly diagnosed with hypercholesterolemia. Her neighborhood suffers from geographic limitations, limited access to full-service grocers, forcing reliance on quick marts. She lacks the time to cook, leading her to default to fried, processed, or microwave meals.
So the economic and geographical constraints are creating an environment where healthy living is almost impossible.
And this environment is compounded by low food literacy within her family. Her children, Eric and Jason, whose BMI is at the 90th percentile, rely on soda and unhealthy snacks while they're under a neighbor's care. Her motivation to be healthy is high, but the systemic barriers, money, time, access, and her family's entrenched habits are enormous.
So for the nurse planning an intervention for Alice, just handing her a brochure about cholesterol is a complete failure. How must the educational plan address the magnitude of her situation?
The nurse has to look beyond clinical instruction. The plan needs to incorporate genuine empathy, address the lack of social supports, maybe connecting her with food assistance programs or community resources, and build her self-efficacy by starting with the smallest, most feasible change, like replacing 1 soda per day with water. The instruction has to focus on the actual mechanics of food literacy, not just what healthy foods are, but how to locate, afford, process, and quickly prepare them within the harsh constraints of her time and budget. The nurse is effectively teaching survival skills intertwined with health promotion.
Let's move to Section 4 and discuss the health promotion models that nurses use to structure educational interventions. We're moving from the abstract difficulty of change to concrete frameworks for intervention design.
Health promotion is all about helping people increase control over the determinants of their health. We start with the Foundational Health Belief Model, or HBM. It's an individual-level model that is invaluable when you're assessing motivation or a lack of it.
And its history is pretty interesting.
It is. It originated in the 1950s when the U.S. Public Health Service failed to motivate people to get free, painless, and convenient tuberculosis screenings. They realized logistics weren't the issue perception was.
They needed to understand the cognitive drivers behind why people weren't acting. What are the 6 components the model identifies that motivate an individual to act?
All 6 are based entirely on the client's subjective perception of reality. So first, perceived susceptibility. Do I think I will get this disease or complication? Second, perceived severity. If I do get it, how bad will the impact be on my life? Third, perceived benefits. If I take the recommended action, will it actually help me?
And then there's the inevitable cost-benefit analysis.
That's fourth. Perceived barriers. Will the change be unpleasant, costly, difficult, or socially awkward? fifth is cues to action. What external or internal stimuli might trigger me to move toward action? And the sixth, which often determines success or failure, is self-efficacy. Do I believe I have the competence and capability to successfully perform the action? The model guides nurses to systematically explore these 6 areas.
Let's apply HPM to June, the 25-year-old newly diagnosed diabetic who is struggling with compliance regarding diet, exercise, and insulin. This is a really common situation for a community nurse.
June's ambivalence is HBM manifest. The nurse needs to assess why she isn't acting. She is likely minimizing her perceived susceptibility. I'm young, it won't happen to me. And questioning the perceived severity. It's not bothering me now, so why worry? Her lack of compliance reflects high perceived barriers related to the cost of food, the time commitment of exercise, and potentially a fear of the needle.
So how does the nurse move the needle using the HPM framework in a conversation with her?
The nurse doesn't argue, they explore. To address perceived severity, the nurse might use a reflection like, "It sounds like you feel the future risks aren't as urgent as the stress you feel today about changing your diet." To boost self-efficacy, the nurse might ask, "You mentioned you managed a complex budget at work. What skills from that process could you apply to managing your blood sugar readings?"
And what about that external trigger, the cue to action?
Right. The sources mention June's friend Sue, who is also diabetic and manages her care well. Sue's positive example acts as a strong external cue to action. The nurse should seize on this, saying, "Tell me more about Sue. What is she doing that you feel you could manage as well?" This connects the abstract benefits to a tangible, successful peer, strengthening June's belief that she can overcome the perceived barriers.
Beyond HBM, which is really about individual-level motivation, we look at stage-based models.
Yeah.
These recognize that change is a process that occurs over time.
Right.
We're focusing on the Transtheoretical Model, TTM, and the similar Precaution Adoption Process Model, PAPM.
These models recognize that people are at different points in their readiness to change, and so interventions have to be tailored to their current stage. The TTM has 6 stages. It begins with pre-contemplation, where the person has no intention of making a change, either because they're unaware of the problem or they're just resistant to addressing it.
So you can't start teaching action until they're ready to even think about it.
That happens in contemplation. This is where the individual starts weighing the pros and cons of changing. They might attend the class about nutrition, but they're still undecided. Next is preparation, where they intend to take action soon and they begin planning. Maybe researching local gyms or making a healthier shopping list.
And then comes that critical transition to action.
Action is the measurable step where they actually perform the behavior. They join the gym, they cook the healthy meal. Maintenance follows, where they accept the new way of living and regularly sustain the behavior. And finally, termination occurs when the change is fully integrated and the old, unhealthy behavior isn't even a temptation anymore.
The PAPM has a similar intent, but it breaks down the pre-action stages a little differently.
It focuses more on the decision process. Its stages are unaware of issue, unengaged by the issue, deciding about acting, deciding not to act, which is a potential endpoint, deciding to act, acting, and maintenance. Whether you use TTM or PAPM, the nurse's takeaway is the same. Never push a preparation intervention on a pre-contemplation client. The intervention has to match the stage.
Can you give an example?
Sure. If someone is in pre-contemplation about switching cooking fats, you provide basic awareness information. If they're in preparation, you provide a coupon for olive oil and a recipe.
Let's shift now to the increasing role of technology in health education. We noted this is a core Healthy People 2030 objective, driven by the enormous benefits technology offers.
The benefits are undeniable. The learner controls the pace, there's tremendous flexibility in time and location, the formats are often appealing, and technology can provide immediate, automated feedback. The pandemic really accelerated technology use across all generations for work, learning, and socialization.
But relying solely on technology creates a critical health equity issue: the digital divide.
This is a major challenge for the public health nurse who's aiming for equitable care. Pew Research Center data from 2019 showed that 10% of U.S. adults did not use the internet at all, and the highest proportion of non-users were adults 65 and older. 27% of that group didn't use it, those with less than a high school education and those with low income.
And these are precisely the groups often most susceptible to chronic illness.
Exactly.
Despite that divide, Social media platforms are vital channels for getting information out there.
Absolutely. Overall, social media use has just skyrocketed, and YouTube and Facebook remain the most widely used platforms. This means the nurse has to utilize these platforms for promotion and education, but with extreme caution regarding content reliability.
Since anyone can post health information, nurses have the professional responsibility to teach clients how to vet online material. The NNLM provides 5 essential criteria for evaluating online health information.
The nurse has to turn clients into critical evaluators. So first they ask about accuracy. Is the information correct? Is it from a reputable site like the CDC, NIH, or a major university? Is it free of spelling or grammatical errors? Second, authority. Are the authors, their credentials, and affiliations clearly listed and credible? Are there references or citations?
Third, they have to look for bias.
That's bias objectivity. Does the site market or sell a product? Is the information trying to persuade you to buy something rather than simply educating? Fourth, currency timeliness. Is there a recent update date? Do the links work? Health information changes rapidly, and stale data can be dangerous. Finally, coverage. Is the information comprehensive, or is it only presenting one side of a complex issue?
The TXT2D-ASHM health program is a perfect evidence-based practice example showing how technology can be deployed effectively, even in hard-to-reach populations.
This program targeted patients with hypertension in free health clinics, a low socioeconomic group. It used weekly text messages over 4 weeks to promote the Daesh diet, and it improved their self-management and nutritional self-efficacy. Critically, the study showed the participants made clear improvements in their dietary behavior, particularly reducing soda intake and fat and oil use.
So the implication for nurses here is that technology works, but it requires addressing that digital divide.
Yes. For a program like TXT2DASH to work equitably, the nurse has to ensure that all patients have access to cellular devices and are comfortable using them, or the intervention will inherently exclude the most vulnerable.
Our 5th and final section focuses on that final, critical step, evaluation, and how nurses can leverage community groups as a really powerful vehicle for change.
Evaluation is not an afterthought. It's a systematic, logical process for determining how to improve the educational program. The nurse has to evaluate 3 things: the educator through feedback, the process, and the product. Evaluation dictates program sustainability and refinement.
Let's clarify the 2 core types of evaluation: process versus product.
Process evaluation examines the dynamic components of the program while it is happening. It assesses the movement and management of information transfer throughout the program. This ongoing feedback, maybe checking in halfway through a 10-week class, ensures that objectives are being met, allows the nurse to immediately correct any misinformation, and provides the opportunity to modify the curriculum if the pacing is too fast or too slow.
So process evaluation is about the how and the mechanism, and product evaluation or outcome evaluation measures the result.
Correct. The product is the measurable outcome of the educational process. This is measured both qualitatively, does the client seem confident in their understanding, and quantitatively, did the client retain 80% of the content. The targets for product evaluation have to be identified when the program is first designed, focusing on changes in knowledge, skills, and abilities.
We also look at evaluation over time, short-term versus long-term.
Short-term evaluation is immediate and easy. You're assessing skill mastery in minutes, like a return demonstration of breast self-examination. If they fail, the nurse intervenes immediately. Long-term evaluation is far more challenging. It focuses on lasting effects. This requires tracking the achievement of community objectives over months or years, often using public health data rather than focusing solely on specific individuals.
And this longitudinal tracking is possible even with population turnover because the nurse is tracking community metrics.
The source material illustrates this beautifully with the Prenatal Care Public Service Announcement, the PSA. The initial goal was to increase the percentage of pregnant women receiving early prenatal care from 60% to 100% over 2 years. After 1 year of just PSAs, the rate only hit 80%.
So it showed improvement, but not enough. The evaluation led to an intervention modification.
Precisely. The nurse recognized that the PSA alone was insufficient. So they continued the PSAs, but they added a new intervention enlisting volunteers to put informational posters in highly trafficked community locations like laundries and grocery stores. In the second year, the rate hit 95%. This demonstrates that long-term evaluation using health department data allows the nurse to track community-wide goals and adjust interventions incrementally for maximum effectiveness.
This level of community impact usually requires working with groups, which are a powerful medium to initiate and implement change, whether they are focused on substance abuse recovery or training for a marathon.
Groups are the critical link between the individual and the larger social system. They influence individual thoughts, choices, behaviors, and values so powerfully. We differentiate between formal groups, which have defined membership, a specific structure, and a clear official purpose, and informal groups, where ties are multiple, the purpose is unwritten, and they form spontaneously due to common interests.
Let's nail down the essential group concepts for the nurse. First, group purpose.
The purpose has to be clear and communicated immediately to all members. A clear purpose establishes membership criteria and provides a non-negotiable action plan. If the purpose is dealing with kids for child and parent satisfaction, then all actions have to align with that dual goal.
Next is cohesion, the attraction among members and the group itself. This seems vital for success.
Cohesion is key to retention and adherence. Attraction increases when members feel accepted, see similarities, share goals, and feel they are part of a valued system. Cohesion decreases due to goal conflicts or deep aversion to certain members. Interestingly, personal differences can actually increase cohesion if they're complementary, if members realize they can learn from each other's unique strengths.
The burn treatment group example is a powerful illustration of this complementary cohesion.
Their bond was based on a common, life-altering trauma and the shared goal of returning to successful life patterns. They learned from complementary differences. The cashier who quickly returned to work and taught others how to handle public scrutiny of their scars, or the person who excelled at physical therapy, inspiring the group's maintenance norms. The nurse's role here is facilitation, pointing out these similarities and redefining differences in supportive, not divisive ways.
Then we have group norms, which are the standards that guide behavior.
There are three critical types of norms that define the group's culture. First, the task norm, which is the commitment to the central goals of the group. Its strength determines how much work the group actually adheres to. Second, maintenance norms, which create pressure to affirm members and maintain comfort. This covers logistical elements like scheduling convenient meeting times, seating, and ensuring refreshments are available.
And the third type relates to belief systems.
Those are reality norms, where members reinforce or challenge their shared ideas of what is real. In a diabetic group, the reality norm defines an uncontrolled diet as harmful, influencing members to maintain control. These three norms combine to form the group's distinct culture.
The final concept here is role structures, the expected ways members behave. The source lists roles ranging from leader to peacemaker.
Every group has these roles. The leader guides direction. The follower accepts direction. The gatekeeper controls external access and internal communication flow. The task specialist focuses on the main work. The maintenance specialist provides physical and psychological support, making members feel comfortable. And the peacemaker is crucial for resolving inevitable conflict.
Let's focus on leadership. It's about balancing task completion with maintenance of the group's morale.
Shared leadership often increases productivity and satisfaction. We have to contrast the two main styles. Patriarchal, or paternal leadership, is authoritarian. One person holds final authority using rewards or threats. While sometimes necessary in acute crisis situations, like a disaster team where immediate task accomplishment overrides morale, it generally leads to low morale, low cohesiveness, and high reliance on the leader.
The democratic style is the ideal for fostering community empowerment and health change.
Democratic leadership is cooperative. It promotes full member involvement in decision-making and planning. Members influence the goals, the steps, and the progress. This model fosters empowerment and self-direction, which is the ultimate goal of community health education.
When nurses choose groups for health change, they can work with established groups or form a selected membership group. What's the advantage of using an established group?
Established groups already have ties, structure, and proven operating methods, which means the nurse doesn't have to build trust from scratch. The nurse simply joins and builds upon the existing community strength, provided the new health focus is compatible with the group's original purpose.
The Neighborhood Council working on homelessness is an excellent application of joining an established high-functioning group.
The nurse assessed that the Neighborhood Council had a 20-year history of success and high commitment, so the nurse didn't try to take over. She joined as a specialist, bringing expertise in health planning and knowledge of the homeless population. She leveraged the council's existing structure to conduct problem analysis and establish solutions, such as collaborating on temporary shelters and joining area coalitions. This maximizes impact by utilizing existing community, political, and social capital.
If an established group isn't suitable, the nurse can form a selected membership group, choosing members with common health needs, like a diabetes management group.
Group size matters here. 8 to 12 is optimal for intensive individual change, allowing every voice to be heard, while up to 25 can be effective for community needs, often through subgroup work. Recruitment is easier when members share similar backgrounds or interests.
Finally, we have to acknowledge that conflict is normal in groups.
Conflict is inevitable, and crucially, it signals that antagonistic points of view must be considered. Avoiding conflict makes a group fragile. The nurse must start by addressing the group purpose immediately, helping members interact, and using the core communication competencies, assessing health literacy, communicating proficiently, and soliciting input to manage discussions. Conflict management should always respect others' rights and beliefs while moving systematically toward problem resolution.
This has been a monumental deep dive, structurally dissecting the art and science of population health education. Before we wrap up, let's quickly recap the essential practice takeaways that you need to carry forward.
We established that health promotion fundamentally relies on client understanding, and it's guided by systematic frameworks like the 6-step educational blueprint and the objectives set by Healthy People 2030. And remember that critical difference between education, the arrangement of events, and learning, which is the process of gaining knowledge that results in behavioral change.
We stressed the 3 domains of learning: cognitive for thinking, affective for feeling and valuing, and psychomotor for physical acting. And we highlighted the absolute necessity of using tools like plain language, Teach Back, and Teach 3 to address the severe, widespread barrier of low health literacy.
And we learned that behavioral change has to be guided by appropriate theory. This requires the nurse to use models like the health belief model for diagnosing individual motivation and the Transtheoretical Model, or PAPM, for staging interventions across the long timeline of change.
Finally, we established that groups are a powerful vehicle for implementing community change. Effective practice demands that the nurse understand group concepts, cohesion, task norms, maintenance norms, and appropriate democratic leadership styles to maximize the impact on public health outcomes.
So what does this all mean for the future of community nursing? We've seen how technology through mHealth programs like TXT2DASH and widespread social media use is increasingly vital for reaching populations. But the Pew Research data highlighted that older adults and those with low income are the least likely to use the internet.
The very populations often most susceptible to low health literacy and poor health outcomes.
Exactly.
So here's where it gets really interesting. Given that persistent digital divide and recognizing that health education is fundamentally an issue of equity and access, what responsibility does the public health nurse have to bridge that gap? How can they ensure that the most vulnerable populations who are least likely to use the internet are not systematically left behind in this pursuit of high-tech health education?
It's a challenge that requires integrating the oldest and newest methods of instruction simultaneously. An important thought to leave with, indeed. That challenge of equitable access is going to define successful community health practice for the next generation.
Thank you for joining us for this deep dive. We hope this analysis gives you a strong foundation for building effective, ethical, and powerful health education programs in your community practice.
And a warm thank you from the Last Minute Lecture team. We'll catch you next time.